So, Sendamil Talvi, are you able to get it, ma'am?
Yes, sir. I'm trying to share, sir.
Yes, yes. Please share.
Yes, sir.
Santosh, can you switch on your video, please?
Sir, I have already switched on. Sir.
Okay, I've requested one of the other college postgraduate to share the PowerPoint. So you can ask whenever you wish to move the slide, she'll help you to move the slides. Are you sharing by yourself?
Sir, can you
Yeah,
see
we are
the...
able to see you. Can you make it full screen? Slideshow mode.
Yes, sir.
Okay,
Okay, sir?
very sorry for the... Yeah, you're okay, ma. Just hold for a moment. Very sorry for the inconvenience, esteemed faculty. We have the student, Dr. Santosh from Stanley Medical College, kindly contributed by Dr. Anandi ma'am. We have very eminent faculty for the day, like Dr. Mayank Tripathi, Dr. Malikarjun Reddy Garu, and we have Dr. Rohit Kumar from BKSMC, and we are expecting Dr. Ibrahim and Dr. Anil Herur shortly. And we have our own in-house faculty joined for the day. We have Dr. Khanna sir, Dr. Rajiv Sakai sir already joined. So the visiting faculty, many of you have already been with our classes. So Dr. Santosh, you will be allowed to present without stop till the history part. Then we will be
Yes, sir.
going back to the first slide to revisit the presentations and ask questions. And if you find difficult to answer the question or if you don't know, please tell the faculty, they'll be able to guide you. All right, same way you will be presenting the second half, the clinical finding, then on the management. Good luck to you, Dr. Santosh. Good luck. You
Yes, sir.
can
Thank
start
you,
the
sir.
presentation. Introduce yourself, your unit chief, your HOD ma'am, and then start your presentation.
Good evening, sirs. I am Dr. Santosh Kumar, final year postgraduate from Stanley Medical College. My chief is Dr. Anandi ma'am, Professor of Surgery, Stanley Medical College, Chennai. I will be presenting a case on carcinoma tongue. A 40 years old male, Mr. Hariharan from Chennai, an auto driver belonging to the lower socioeconomic status, presented with complaints of ulcer in the left side of the tongue for 3 months, complaints of pain over the ulcer for 1 month. History of presenting illness. The patient was apparently normal before 3 months back, after which he noticed an ulcer in the left side of tongue, which was present for 3 months. Ulcer was insidious and onset. The ulcer was started as a small ulcer in the left dorsal aspect of the tongue, gradually progressed to involve left lateral and ventral aspect of the tongue. The ulcer was not associated with any discharge. History of pain over the ulcer, which was present for 1 month. The pain was insidious and onset, progressive, dull aching, continuous pain, not radiating and referred to here. The pain was aggravated on speech and taking food in, taking hot spicy food. There was no relieving factors. There was a history of excessive salivation, halitosis, difficulty in speech, and difficulty in tongue protrusion and mobility. There was no history of dysphagia, difficulty opening the mouth, no history of hoarseness of voice, no history of ear pain, no history of recent loosening of tooth, no history of trauma from sharp tooth or dentures, no history of cough with expectoration, evening resort temperature, no history of neck swelling, no history of loss of weight and loss of appetite. There was no history of swelling elsewhere in the body. Comorbid history, the patient was not a known case of diabetes mellitus, hypertension, coronary artery disease, tuberculosis, bronchial asthma, epilepsy, jaundice. Past history, there was no history, previous history of ulceration, otitis or reddish patch in the tongue. No, there was no history of previous surgeries in the oral cavity. There was no history of tooth extraction for a short tooth. There was no history of ill-fitting dentures. No history of sexually transmitted diseases. No history of chronic drug intake. Personal history, he consumes mixed mixed diet, normal bowel and bladder habits. It's a no, smoker for the past 20 years. He smokes 4 cigarettes per day. Number of pack years 4. He consumes alcohol for the past 20 years. A daily drinker. He stopped taking alcohol for the past 1 year. There was a history of tobacco usage for 20 years. Stopped using tobacco for the past 1 year. History of spicy food intake. Family history, no history of cancer deaths in the family. Summary: a 40 years old male who is a chronic smoker and alcoholic with a habit of tobacco chewing. Presently with chief complaints of ulcer over the left side tongue and pain over the ulcer. The history of difficulty in speech, difficulty in tongue protrusion and mobility, excessive salivation, and halitosis.
Dr. Santosh.
Shall I
evening.
continue, sir?
No,
Yes, sir.
let's get to your history first. Let's go to your first slide.
Yes, sir.
Okay. Just before we start, how is carcinoma of tongue different from other oral cavity cancers? Is it good, bad? How is it different?
It's most aggressive tumor, sir.
Is it very aggressive, or are there
Yes.
other reasons for why is it more aggressive?
So it has tongue has a extensive lymphatic drainage, sir.
Right. Okay, good.
So
Okay. So he's a auto driver, lower
Yes, sir.
socioeconomic group, also left side of tongue.
Yes, sir.
Is it left side or is it margin issue? Is it on the margin or it's on the
So
dorsal
it was
surface?
over the dorsal aspect tongue, involved with involvement of lateral border and ventral surface of tongues.
Okay. And pain over the ulcer. Okay, next slide, please.
Yes.
Okay, the ulcer appeared without any pre-existing lesion.
Yes, sir. There was no pre-existing lesion on the ulcer sides.
Okay. Started a small ulcer, left ulcer. Okay. Could you tell us? Could he tell you the size of the ulcer when he noticed it first?
So initially the ulcer was 1 cross 1 centimeter, sir. Now it has
And
attained a size.
Yeah,
Sir?
go on.
It was on the dorsal left dorsal aspect of tongue, sir.
So you can write this out, right? Why is it important?
So size of the
Is
ulcer
the
is important for staging.
No, is the undersurface of the involvement of the undersurface of the tongue different from involvement of the dorsum of the tongue?
Yes, sir. There may be infiltration of floor of mouth
And
and mandibles.
no, and that could be infiltration. But because the saliva is bathing the floor of the mouth, there's a field cancerization. It can involve a large area,
Yes, sir.
right? Also, the floor of the mouth has got non-keratinized stratified epithelium, while the dorsum has got stratified squamous, right?
Yes, sir.
Okay.
Yes.
So insidious also not associated discharge. What do you mean by that?
Um,
What kind of
there
discharge?
there was no
Are you
any
looking-
discharge from the ulcers or like
What kind of discharge are you looking for?
uh,
Look, this
no.
sentence means nothing. Either there's
Yes.
bleeding. I mean, discharge, what is it? You think it's pus there or something infected? Okay. Next slide, please. Pain. Why is he getting pain? What is the
So due
pain?
to the infiltration of nerves by tumor growth, sir.
So this tells you that it is quite advanced, right? It's
Yes.
involving the neurovascular bundle.
Yes.
Again, insidious onset. The pain is insidious on onset.
Yes, sir.
Not radiating, not referred. Okay, no relieving factors. Next slide, please. Excessive salivation. Why do they get excessive salivation?
Sir, due to the mass effect of the ulcer and also due to the patient unable to swallow, there may be pooling of the saliva.
So does he have any difficulty in swallowing food or water? Have you written difficulty in swallowing anywhere? You've not,
Yes.
right? So you'll have to
Yes.
make a mention of that.
Yes.
Why halitosis?
Halitosis. Foul smelling is due to the formation of mer mercaptans.
No, that's fine. But why were captains formed?
So due to the infections.
Okay, there can be infection. There can be tumor necrosis,
Yes.
right? Dental caries, poor oral hygiene,
Yes.
difficulty in speech. Okay, difficulty in protrusion or tongue protrusion mobility. What does that tell you?
So infiltration of muscles of the tongues, deep muscles of the tongue.
Okay, hoarseness, ear pain, loosening. Okay, right. Next slide, please. Next slide. Does not no tooth involved anywhere. Okay, next slide, please. Chronic drug intake. What do you mean by why did you ask for that? Chronic drug intake.
So,
What drugs? Okay. Do you think there are any drugs involved in causing malignancy of the? Not that I know of. Anyway, next slide, please. Okay, yeah. Okay, consume. Why alcohol and smoking? How do they alcohol and smoking and tobacco? How do they uh, how are the risk factors?
both tobacco and alcohol have synergetic effect of sir.
No. So how does is alcohol associated with how does alcohol affect?
Sir, it facilitates the pro-carcinogenic effect of tobacco usage.
Yeah, it dissolves the carcinogens.
Yes,
Right?
sir.
Okay. Next slide, please. Next slide. Yeah, don't say alcoholic. An alcoholic
Yes,
is
sir.
a person who's got dependence on alcohol, right? So if there's no alcohol,
Okay.
he's gets all these features of chronic alcohol withdrawal, right? Alcohol withdrawal. Just say that he's
Yes.
chronic alcoholism or consumes alcohol, right? Like a written smoker, same thing with alcohol. Okay,
Okay.
right. So anyone, please.
Dr. Santosh, can you tell
Yes.
what is oral cavity?
Sir, oral cavity extends from the perimeter border of the lip up to the junction of soft palate and hard palates.
Okay. Uh, what are the common subsites for oral cancers?
Sir, lips and cheek, lip and buccal mucosa, sir, floor of mouth and alveolus.
Yeah, it's buccal mucosa, gingivobuccal sulcus, the
Yes, yes.
anterior two-third of the tongues and floor of the mouth alveolus. Okay. And most common, if you go by histology, most common type of oral ulcers are which type?
Squamous cell carcinomas.
Okay. And what is field cancerization?
Sir, due to the exposure of uh, tobacco and smoking, tobacco and alcohol, there may be multiple cancers in the oral cavity and upper digestive tract, sir. There may be synchronous and metachronous lesions. Patient may be present with secondary cancers at the same time.
What are the potentially malignant disorders? Can you give some examples?
Sir, yes, sir. Leukoplakia, erythroplakia, and chronic hyperplastic candidiasis, syphilis, discoid lupus erythematosus, and dyskeratosis congenitas.
Okay. And
These can cause a
Hmm.
yes, sir.
While taking history, which history of which virus you want to take?
Sir, human papilloma virus, sir.
Okay. And what history you will take in this? How will you take? What you will ask from the patient in history?
Sir, any contact history, sexual history, and the endemic is residency, sir. Some places HPV is endemic.
No, what you will ask? You will ask for any what? Okay.
What? Okay.
And can you give
the difference between HPV associated oral cancer and HPV non associated? Could you hear me, Dr. Santosh?
Santosh?
Sir? Hello, sir?
Hello.
Hello, sir? Can you hear me?
Yeah, yeah, I can hear you. It's asking that what is the difference between HPV associated cancer and HPV non associated cancer? Yeah.
Sir, oral cavity lesions are associated with the HPV virus infection, sir. Most common type 16,
Which
sir.
part of the oral cavity is involved by the? Yeah, it is okay. HPV 16 is there. But what is in the clinical presentation of a patient who has HPV positive and who does not have the HPV infection?
No,
What is the location of the HPV associated cancer?
sir, oropharynx.
The posterior part of that.
Yes, sir.
Or the oropharynx. Then
Posterior part of tongue and
in the HPV test.
okay, sir.
One has got the better prognosis.
Sir, HPV negatives.
Or HPV positive, sometimes they have the better prognosis than the HPV negative.
Okay.
Even though
What is the difference between cancer? Hello.
Yes, sir. Hello, sir.
Santosh?
Yes, sir.
Are you able to hear me?
Yeah.
Sir, now I can hear you, sir.
Hello.
Hello, sir.
Santosh. Yeah, as you are in history, let's stick for the only questions from the history itself. So you asked, did you ask for any, Rajiv sir, somebody asked about the difficulty in swallowing.
Sir, there was no difficulty in swallowing.
Why? Why it is important? What it gives? What information it gives?
Sir, the extension of ulcer into the posterior on the tongue.
Yeah, very good. So you have to know that because you are in history, you don't know about the examination. Okay, based on, so you have to put more number of questions, you have to grasp the information.
Yes, sir.
Because you are not touching the patient. You're only keep on asking multiple questions.
Yes, sir.
So one thing is the extension. You can know whether there is any difficulty in swearing or slurring of speech.
Yes, sir.
Okay. And
Yes, sir.
these things you asked any referring pain. Why did you ask that?
Yes, sir.
Yes. Why did you ask that?
Sir, tongue is supplied by lingual nerve, sir. In case any irritation of nerve, there may be referred pain to the ear because both lingual nerve and auricular temporal nerve is a branch of mandibular nerve of trigeminal nerves.
Yeah. Why are you thinking it is infiltration? Means why
So
are you?
any
Yeah. No.
infiltration or irritation?
No. Why you are thinking in terms of malignancy? How are you differentiating between a benign and malignancy from your history? History itself. Don't go into the examination. I am asking only based on your questions. You will come. Okay. This is going towards malignancy. It is going towards benign. So what are the points which are favoring towards malignancy?
Sir, it's a non-progressive, progressive non-healing ulcers.
Yeah, it's progressive. One thing is progressive. Yes.
Yes, sir. And non-healing ulcers.
Yes. And other symptoms, and his other habits, all those factors. What are all the risk factors? Because they have to correlate all these things.
Sir, a long-term exposure of tobacco and smoking
Yes.
alcohols.
Yes. Yes.
That's
Hello.
yes, sir.
Yeah. Continue. You only put so many questions, na? Halitosis,
Yes, sir.
excess salivation.
Yes, sir. So excessive salivation due to the bulk or mass effect of ulcers.
Yes. And difficulty in opening of the mouth.
So there was no difficulty in opening them.
Means why you put all these questions? That's what I'm asking.
So in case of extension of ulcer into the retromolar trigone, there
Yes.
may be uh, inadequate mouth openings, restricted mouth openings.
Yes. To know the extent of the lesion,
Yes,
you have to ask, put all these questions from history itself. You can get a picture.
yes, sir.
Okay. If number of the ticks are going more towards all these questions positive, that means you are getting a picture that it is a extensive disease.
Yes.
Okay. If it is a positive, that is there is a referred pain, there is any cough with expectoration or difficulty in opening of the mouth, and it is a progressive ulcer, excessive salivation, drooling, everything it is going towards a positive features more towards a extensive disease.
Okay, sir.
So you have to keep in mind that you are dealing a advanced condition. A patient
sir.
presented a late, so that gives so the questions, more questions you put, the more answers you get, and you'll get a picture to what to do next. Okay.
Yes, sir. Yes, sir.
And based on the, if you think in lines of malignancy, what are the questions you have asked regarding the metastatic symptoms?
Sir, any neck swellings, the history of cough, breathlessness, hemoptysis, sir.
Yes. You asked about evening rise of temperature. Cough expectation with evening rise of temperature. Why is that?
Sir, it's rule out tuberculosis.
Tuberculosis ulcer of the tongue.
Yes, sir.
Is it more
And
common?
the patient may have a simultaneous lesion in the lung and the larynx also.
These are rarity. You have to go for more common things first.
Yes.
Okay, rare possibilities. So in examination, as a PG student, you have to go for a more common diagnosis.
Yes.
Okay, not the combination rare thing. In Viva, you'll have to ask what are the other combinations. Okay.
Yes.
Yeah. You can go ahead.
Yes. General examination, the patient was conscious, oriented, moderately built and nourished. Physical status, ECOG, class 1. There was no pallor, icterus, cyanosis, pedal edema, clubbing, and generalized lymphadenopathy. Hydration status adequate. Halitosis present. Drooling of saliva present. Yes, vital signs: pulse rate 76-minute regular rhythm, normal volume, regular character, no radio-radial and radiofemoral delay, equal in all peripheral valvular vessels, no vessel wall thickening. BP 120/80 millimeter mercury measured in left upper arm, in sitting posture. Respiratory rate 18 and it was examination after getting consent. Inspection, the mouth of
Santosh, Santosh, I want to stop here. Hello.
yes, sir.
Yeah, what is the temperature ephemeral means what? Hello. Can you hear me? Hello.
Sir, yes. Hello, sir.
Hello. Yeah, what is the temperature ephemeral means what? Santosh.
So temperature is
Hello, your voice is not. Hello. Santosh.
Sir, looks he is having some issues, sir.
Yes,
Kindly
sir.
bear with me, sir. I'm
There
trying
is.
to reach out to him. Got disconnected.
Yes, sir.
Allow me a few minutes.
Sir, good evening, sir. Kanagal, sir.
Yes, sir. Tell me, sir.
Sir,
Please
good
come.
evening. Well, just a good evening.
Good evening, sir. Good evening, sir. Good evening, sir.
Just to break the silence.
Yeah, yeah. Please, sir. Please. Give me a moment, sir.
Yes.
hello, sir. Hello, sir.
Yes, Santosh, we are able to hear you. Please proceed.
Santosh.
Sir, still he is not fully connected, sir. Please wait, sir.
Again, he was disconnected.
Maybe next week onwards, I'll try this twice, few days before only to have a trial connection with me. I don't know. This system of 15 minutes before joining doesn't seem to help for very commonly these things happen, but unfortunately it should be sorted out. So I will take care of this in future, sir.
So, what I do routinely, sir, just for an information, I have two phones of different networks. So, sometimes one network goes on, off, you can use the other network. So, sometimes it helps.
faculty, I think some the challenge. Yes, even 5 10 minutes, if not, it's difficult to join. Santosh, are you with us?
Hello, sir. Hello, sir. Hello, sir.
Yeah, Santosh.
Sir, hello, sir. Can you hear me, sir?
Yes.
Sir, sorry, sir. There was a network issue, sir.
Yeah, I stopped you at temperature is febrile. What is that statement?
Sir, at the time of
No.
yes, sir.
When you put a heading, subheading, temperature means you have to mention the degrees.
Okay, sir.
The patient is febrile. Okay, correct the statement because everywhere all the P's, all the U's use the same statement. The temperature is febrile. The patient is febrile.
Okay, sir.
Okay,
Okay, sir.
continue.
Yes, sir. On examination of oral cavity, inspection, mouth lips, no- normal, gums, alveolus normal, are canine, and
Signal was very poor. Can't hear presentation.
premolar and molars, tongue, a single ulcer of which was extending anterior, posteriorly up to the retromolar, up to the surrounding area of ulcer looks edematous. Retromolar trigon is normal. Is normal. The inspectory findings of the ulcer size, shape, and extent or base of ulcer for about 0.5 centimeter from the edge. The ulcer bleeds on touch. There was no mandibular thickening or irregularities on bidigital palpation. It's a clinical image of ulcer. Examination of neck nodes. There was no palpable lymph nodes in the neck. Other system examination. CV normal vesicle is heard, no added sounds. Abdomen soft, no tender, no organomegaly, no palpable muscle. Hernial orifices are free. Cranium normal. Summary: a 40 years old male who is a chronic and patient an ulcer of size 6 centimeter present. The left the diagnosis is a case of uh, hello sir. Hello sir. Hello sir.
Hello.
Hello sir.
Yes, Santosh, are we audible?
Yes sir.
Yeah, actually your network is poor
Hello
and we
sir.
could not hear.
Hello sir.
Hello.
Hello sir.
There is a
Hello.
lot of
Hello.
sound. Lot of sound.
Hello sir. Sir, it's raining outside sir. Sorry sir.
Okay, okay.
Hello.
Hello sir.
Yeah, are we audible?
Yes sir.
Yeah. Okay, Santosh, what are the anatomical landmarks in CA tongue in relation to which you examine an ulcer? I mean, what are the area you look for while you describe the ulcer? While you
Sorry sir.
describe the extent of ulcer. So what are the
Sir,
anatomical landmarks in relation to which you examine an tongue lesion or a tongue ulcer?
sir from the tip of the tongue, the ulcer extends up to the level of treatment trigon, sir. Medially up to the midline, and laterally it
Hmm.
crosses lateral border, left lateral border, and extends up to the ventral surface, sir.
Okay, so basically if it's crossing the midline or it's reaching the posterior, what is the border of, base of tongue and anterior tongue? Is there a anatomical landmark which differentiate these
Uh,
two
sir,
areas?
sir, sulcus terminalis, sir.
Yeah, and
Hello, sir.
the photo, can you show us the your slides? I'm not able to see
Yes,
your slides actually.
yes, sir. So can you see, sir?
Yeah, can you show me the clinical picture again, the slide of your
Yes, sir.
clinical picture? Yeah, can you just put the slide? Yeah, only the picture of that lesion. Yeah, oral tongue. Yeah, this one. Can you? Okay.
Can you,
So yeah. So can you describe it again?
sir,
This is,
the yes, sir.
yeah, describe it again. just the extent of this ulcer?
Sir, the ulcer extends from the tip of the tongue anteriorly, posteriorly up to the level of retromolar trigone. The laterally it reaches a midline, and medially it reaches the midline, sir. Laterally it crosses the lateral border of tongue and extends up to the ventral surface, sir.
Okay. So it's crossing the midline, right?
Sir, the ulcer edge up to the midline, sir. Indulation crosses the midline, sir.
Hmm. And do you think there is deviation of tongue or there is restricted movement of the tongue in this patient?
Sir, restricted.
We lost him.
He could not. Hello, sir.
If we were talking about the movement of the tongue, is it restricted or it is deviated on any side?
Sir, movements are restricted, sir.
Is there a deviation?
Sir, uh, there is deviation to left side. Hello, sir.
Santosh,
Yes, sir.
yeah, tell about
Hello.
you put a staging. Tell about the staging.
Sir, this case, stage 3, sir.
Hmm. Audio was not clear.
Stage,
It is breakup. Yes. Hello.
hello, sir.
Yeah, did you tell something?
Hello, sir.
Yeah, staging. Ask regarding.
Sir, T1 is size, tumor size less than 2 centimeters, sir, and depth of invasion less than 5 mm, sir. T2 is tumor size less than 2 centimeter, less more than or equal to 2 centimeter, but less than 4 centimeters, sir. And depth of invasion less than 5 mm, And T3 is tumor size more than 4 centimeter and depth of invasion is more than 10 mm, sir. T4A, the extension into the deep infiltration into the muscles, soft
What is
soft palate.
T3?
So T3 size more than 4 centimeter and depth of invasion more than 10 millimeters, sir.
Everything is more than 4 centimeters.
Sir, size more than 4 centimeter and depth of invasion more than 10 millimeters, sir.
Hmm. Hmm.
And
What is depth?
T4B,
What is depth of invasion?
sir, depth of invasion is distance at the level of basement membrane of the normal adjacent cells to the maximum depth of tumor invasion, sir.
So you think that tumor thickness and depth of invasion is same thing?
No, sir.
Yeah. Proceed. Continue.
Yes, sir.
Notes.
See, investigation, I'll
Notes.
start with the routine.
Nodal staging.
Hello, sir.
Nodal staging. Nodal.
Staging N1, yes, sir. Yes, sir. Nodal staging N1 single ipsilateral node less than 3 centimeter, sir. N2 A single ipsilateral node less more than 3 centimeter but less than 6 centimeters, sir. With and N2B multiple ipsilateral nodes less than 6 centimeters, sir. N2 sees multiple bilateral or contralateral nodes less than 6 centimeters, sir. N3 any node more than 6 centimeters, sir. N2 is divided into N3A and N3B, sir. If there is a external extension negative, say N2 N3A, sir. If there is a external extension positive, say N3B, sir.
Yes. This was given by.
Hello, sir.
Staging was given by.
Sir, staging is. Hello, sir.
Yeah.
Sir, I can't hear you, sir. Sorry, sir.
Staging. The staging was given by which group?
Sir, AJCC, sir.
Yeah.
American. Yes, sir.
Yes. Tell me. American.
American Joint
Hmm.
Cancer Committee, sir.
Hmm. Yeah. Now stage grouping comes under.
Sir,
Stage grouping for this case.
sir, it's stage 3, sir.
Yeah, because T3 and N0 or N1 comes under stage 3.
Yes, sir.
Yeah. What will you do next? How will you confirm your diagnosis? How will you confirm your
Sir, I'll confirm the diagnosis by doing biopsy, sir.
what about biopsy?
Sir, edge wedge biopsy, sir.
Yeah, edge wedge or wedge biopsy.
Sir, edge wedge biopsy, sir.
What is that? What do you mean by that edge biopsy or wedge biopsy?
So we have to take tissue from the margin of the ulcer and also from the normal tissue, sir.
Why?
Sir, to look for the depth of invasion and to differentiate between the normal tissue.
Why not from the center of the ulcer?
Sir, center contains necrotic tissue, sir. So the yield will be less, sir.
Yeah, it may lead to false negative.
Yes, sir.
Also, from the edge in the same slide, the pathologist can see the normal cells from the normal tissue and also abnormal cells.
Yes, sir.
So that's why you have to wedge
Take
by
it from the edge. Yes, sir.
from normal tongue and from the ulcer. Right?
Yes, sir.
Yeah. How do you proceed with the case investigation?
Sir, in this case, first I'll do biopsy, sir. Then
Yes.
radiological imaging. I will do CCT neck to look for the lymph node status and bony involvement, and
Then
MRI for soft tissue
you
infiltration, sir.
you go from initial line of investigation, then to go to the advanced investigation. Can do there are initial investigations of choice. Okay.
Sir, for neck, I'll do USG, sir.
Yeah, initial
USG
investigation. Then the question comes whether which investigation is better next, like this. Okay, you have to know all the modalities
ultrasound
and all the modalities of investigations. Okay, initially
neck.
ultrasound.
Ultrasound neck, sir.
Ultrasound neck. What do you want to? What information you want to get from ultrasound neck?
Sir, to look for lymph nodes enlargement, sir. Whether
Yes.
it's a benign or a malignant.
How to differentiate?
Sir, normally the lymph nodes will be bean shaped, sir.
Yes.
The shape will be altered, sir, and there is loss of fatty hilum, sir.
Yes. Very good.
Yes, sir.
And group of lymph nodes called.
Sir, if in the carcinoma tongue, level 1A, 1B, and level 2 groups are involved, sir.
Yeah, based on the location of the ulcer. One is based on the location of the ulcer,
Yes, sir.
and the most common group involved is level 2.
Yes, sir.
Yeah, jugular group of lymph nodes, level 2 are the most common.
Yes, sir.
Yeah, ultrasound next.
So then next, if there is any node, I'll do by FNAC, sir.
That's okay. Next investigation.
Next, CT neck contrast and as CT to look
So
for
directly for CT only. I told come for the basic investigation. What you can do, then you can go to CT.
sir,
And to do a X-ray.
X-ray to look for any pulmonary metastasis,
Chest X-ray.
sir.
Chest X-ray for
Sir, chest X-ray for lung metastasis, sir, and
yes,
also for any signs of aspiration,
yes.
infection.
Because so next question comes, what is the best investigation? Investigation of choice. Then you can go ahead for CCT neck, which gives a overall 3D picture about the disease.
Yes, sir.
So we have to know whether ultrasound has a role or not. We have to know the chest X-ray has a role or not. If there is a chest X-ray with the patient, what you want to look for? Okay, like that you have to tell all the multiple investigations which we can do in a patient.
Yes, sir.
Yeah, CCT. You are to continuously. You are more. You are a fan of CCT of the neck. So, what is the information you want to get from CCT?
Sir, from CCT, lymph node status,
No. First,
sir, tumor size, extent, sir.
tumor. Yes.
Sir, tumor size and extent,
Yes.
bony involvement, then lymph node involvements.
Yeah, infiltration involving the surrounding structures most important because clinically only to some extent we can assess whether it is involving the mandible only palpation. Okay, it is
Yes,
more
sir.
on CT you can see any bone irregularity,
Yes, sir.
involvement of the deeper structures and the posterior extension which we uh, can't assess in all the cases because the patient may not be cooperative. So in CT you can know the exact extent in it because it's 3 dimensional. You can get a 3 dimensional and lymph node status, involvement of the
Lymph node status.
vascular structures in the neck. If there are involvement of the, if at all there is an involvement or enlargement of the lymph nodes, cervical lymph nodes, the group of lymph nodes, size of the lymph nodes, and the status of the lymph nodes, whether they are necrotic lymph nodes, conglomerate mass, involvement of the vascular structures. Most important is involvement of
Internal.
vascular structures.
Yes, sir.
So it gives a overall staging. The radiological investigation, the CCT, along with the pathological investigation. So this gives a overall picture for your management of the condition.
Yes, sir.
So that's how you have to proceed. You have to clinical examination, your biopsy pathological, next you are doing imaging, and your overall picture you get a stage what to do next, like that. So other investigations apart from this. Hello, Santosh.
Took for
Santosh.
Hello, sir.
Yeah, other investigations.
Yes, sir. Sir, MRI oral cavity, sir.
MRI means all the cases you want to do CCT, MRI.
No, sir.
Why MRI? Already you told CCT neck. Means,
Sir,
are you
MRI for sir, soft tissue infiltration and volume assessments.
means is it recommended to do MRI for all the cases? It is a routine investigation MRI for all the cases.
No, sir.
No. Okay.
Yes, sir.
So for any during case presentation, it is not a theory presentation. Okay, it's not like a seminar. For case presentation, you have to stick to what are the investigations necessary for this case.
Yes, sir.
Not all the generalized investigation, because you should not put a list of investigations which is given in the book. For this case, for your staging or for your diagnosis, so these are the investigations necessary. Okay, you should not write all the
Yes, sir.
investigations in the book. And indications.
Okay.
Why you are doing that investigation? I am doing ultrasound neck. From ultrasound neck, I want the information like that. CCT you told like. Okay, next.
Yes, sir.
Yeah, radiological. Next, any laboratory. Blood workup. Hello.
I'll sir, routine
Yes.
blood sir, bleeding and urine routine day. Echo renal sir.
Santosh.
Sir, hello, sir.
Yeah, tell me. Did you tell something?
Hello, sir.
Can't
Yes,
hear
sir.
you.
Sir, I can't hear. Yes, sir.
There is a
Can
break
you
in
hear me?
your. Yeah. Now it is.
Yes, sir.
Hmm. Tell me. The-
Sir, there was a network issue, sir. What was the questions? Sorry, sir.
Yeah, you told some. You want to do some ENT examination. You want to send for a ENT specialist.
Sir, in direct and indirect laryngoscopy, sir, to look for the extension of ulcer into the posterior one-thirds.
Hmm. Next.
Yes, sir. Next treatment
Hmm.
part.
Santosh,
Yes, sir.
you said that DOI is the part of staging, right? So how do you assess DOI? What is the best way of knowing that what is depth of invasion?
Sir, histopathology.
No, clinically, what I mean, to, you have to give a clinical staging, right?
Yes, sir.
So you have to have some assessment, no, of expected depth of invasion.
Okay.
What is the most accurate tool for that to know what will be the DOI? MRI, right? So
Yes,
MRI
sir.
is something which is now it's kind of we do MRI for all tongue lesions because we have to be sure that what is because their extension is more into the muscle, they sometimes cross the midline, which you may not feel clinically. And margin is very important for CA tongue. So if you do a positive margin, then it will be a problem. So
Yes.
MRI, you can say that probably it's now included, unless it's a very superficial ulcer, which is very rare. We almost do it always to assess the extent of the lesion.
Yes, sir. Sir, shall I proceed?
Yeah, you can go ahead.
Any other faculty? Do you have any questions, sir? Kanna sir, other senior faculty, Rohit sir, Mallikarjun sir? You please proceed.
Proceed, Santosh.
Sir, treatment part, I'll proceed with multimodal treatment, sir. For this case, I'll choose first neoadjuvant chemoradiation, followed by
What is
reassessment.
the clinical stage?
Sir, stage 3, sir.
What is the clinical stage? What is TNM for this patient?
Sir, T3N0MX.
For a T3 lesion, you want to give neoadjuvant therapy without a node.
Sir, since it's a large tumor which crossing the midline, so to downstage the tumor, we can give chemo radiation, radiotherapies.
So in neoadjuvant setting, you give chemo radiation or just a neoadjuvant chemotherapy?
Sir, radiotherapy is preferred, sir. To facilitate the action of radiotherapy, we can give chemotherapy also.
No,
It's called
actually, that's
chemo.
not true. So in head, neck, and oral cancers, we will prefer to give NACT rather than NACTRT. If you are not sure that you can resect it, you may choose definitive CTRT. But if you think that by downstaging this tumor you can resect it, then probably the NACT is a better option as per the available evidence. Okay.
Okay, sir.
Plus, I mean, suppose, uh, so what all the surgeries you know for a tongue lesion?
Sir, for a smaller lesion, we can less than 1 centimeter. We can do wide local excision with 1 centimeter margin, sir. For a
Hmm.
size more than 2 centimeter, we can do partial glossectomy, hemiglossectomy, sir. Followed by
Okay. So
reconstructions. Followed by reconstructions.
anything else you want to do? Suppose it's a resectable lesion, T2 lesion,
Sir,
T2N0
treatment.
lesion. What will you
Sir,
do?
sir, T2N0. I'll do
It's a 2 centimeter lesion, lateral border of tongue. There is no palpable node. What will you do?
sir, wide local excision with 1 centimeter margin with suprahumeral dissections.
Even if there is no node.
Sir, yes, sir. Prophylactic neck dissections.
Okay.
In 20 to 30% of patients, there will be occult metastasis, sir. So we'll do neck dissection also.
Okay, I suppose you did the surgery and there is one node positive, then
Sir, if the node is positive, I'll proceed with the modified radical neck dissections.
yeah. So if this particular thing is only possible prophylactic, most of the time you have to be sure that there is no node. So the best way in a best setting is to do a frozen section for our supraomod head dissection nodes, and if they are negative, then it's fine. But if they comes positive, you have to go ahead and do a modified neck dissection on that side.
Yes, sir.
Plus, suppose it's a T2 N2 lesion, N2 nodes, but they are still mobile ipsilateral.
Sir, wide local excision with the on modified radical neck dissections.
Yeah. Plus, it's recommended that you do a prophylactic SOHT of opposite side, right?
Yes, sir.
So again, tongue has bilateral lymphatic drainage, right?
Yes, sir.
So many of the time, if crossing midline or if a centrally located tumor, you may have to opt for. If it's N0 neck, you have to opt for bilateral prophylactic SOHT. So in
Yes, sir.
this patient, okay. So, and what are the reconstruction option of the tongue dissection? Suppose you have done a extensive tongue resection near total glossectomy. So what all you can do to reconstruct it? You know of some options?
Sir, for reconstruction, you can have local flaps, regional flaps, and free flaps, sir.
Hmm.
The free flaps are best, sir. It provides uh, adequate volume and functional outcomes.
What are the regional flaps you know of for any head neck surgery? Do you know of any regional flaps, local regional flaps?
For regional flaps, we have temporalis or platysmal flaps and latissimus dorsi, delta pectoral, and pectoralis major myocutaneous flaps, sir.
Hmm. PMMC is probably the most commonly used flap in
Yes,
all
sir.
head neck surgeries. They are
Yes, sir.
very robust flaps, and yeah. So you should know what is PMMC. That is important for a general surgeon also.
Yes, sir.
Yeah, can go ahead. I think.
Thank you, sir. Hello, sir. Yeah. Hello, sir.
Yeah, so
Sir. Yes, sir.
classification of the neck dissections.
Sir, I can't hear you, sir. Sorry, sir.
Neck dissection.
Yes,
Tell
sir.
about classification of the neck dissections. Different neck dissections.
Sir, radical neck dissection, modified radical neck dissection, and selective neck dissection, sir.
Yeah, continue.
So in modified neck dissection, we'll remove level 1 to level 5 lymph nodes and other structures like submandibular gland and spinal accessory nerve, external jugular vein and internal jugular vein, and sternocleidomastoid muscles, sir. In a modified radical neck dissection, there are types, sir. In level 1, will preserve,
Type
uh,
one.
sir.
Type 1, not level 1.
Okay, type 1 is a type 1 will preserve a spinal accessory nerve, sir. In level type 2 will preserve spinal accessory nerve and internal jugular vein, sir. In type 3 will preserve spinal accessory nerve, sternocleidomastoid muscle and internal jugular vein, sir. In a selective neck dissection, we have a suprahomoia dissection, sir. In that we'll remove level 1 to level 3 nodes. In extended suprahomoia dissection, we'll remove level 1 to level 4 lymph nodes. In lateral neck dissection, we'll remove level 2 to level 2, level 3, and level 4 nodes, sir. In posterolateral neck dissection, we'll remove level 2 to level 5 lymph nodes, sir.
Yeah, when you do that selective neck dissection?
So, in case of clinically negative neck nodes.
Yeah, N0 clinically negative lymph nodes.
Yes, sir.
And also less morbidity, those things, because this all the lymphatic structures are preserved.
Yes, sir.
So you are selectively going and remove the means these lymph nodes can be involved based on the location of the ulcer of the tongue.
Yes, sir. Hello, sir.
Faculty, any other questions, sir? Please, other faculty.
Santosh,
Yes, sir.
when there are large fixed lymph nodes, what will you do?
Sir, if there is a large fixed node, I'll first go for radiotherapy, sir.
Yeah.
Fixed nodes are contraindication for surgeries.
Yes. What could happen? Any sudden emergency, patient may land in sudden emergency, sudden mortality. What is the reason?
Sir, due the metastatic nodes may erode the arteries, sir, internal carotid artery. There may be torrential bleedings.
Yeah, that is one of the
There may be the uh, complication of more dangerous complication of carcinoma.
yeah, it is one of the cause of sudden death because of the
Yes,
erosion of the artery.
arteries. The patient may also have aspiration, asphyxia also.
Yes. One is
Yes,
the posterior one of the tongue is involved. The patient what is the
sir.
treatment of the posterior one third tongue lesions? Any such modality?
Sir, for posterior and third, we'll give radiotherapy.
Yes.
So, Santosh,
Yes,
so what the current evidence is actually for any borderline resectable cancers, like in a CA tongue where you are thinking that probably you will not be able to get an R0 margin, the best
yes,
strategy is probably to give NACT. Okay, so we do not prefer NACT-RT for these lesions
okay,
because if you are planning surgery, it will increase your morbidity. It's
okay,
very difficult to operate on an irradiated field, that too inside the oral cavity, which also requires reconstruction like free flaps.
yes, sir,
So we need good vessels uh, quality and other things to do a free flap reconstruction.
yes, sir,
So as of now, the current evidence is strongly for if you want to give, or ideally if you should do a surgery whenever feasible for these patients. But if you think that surgery is not feasible and they are still curable patients, probably NSCT is a better option as of now.
okay, sir.
Else you are thinking that surgery is not an option, then probably a definitive CTRT.
What
Hello,
are the
sir.
methods of radiotherapy? radiotherapy. Tell about the radiotherapy. Hello. Santosh. Santosh.
Sir, I
Hello, sir.
wish we will stop here, sir, because he's been having continuous problem. I don't want the senior faculty to be kept waiting forever. So, Santosh, do you have any challenges? Maybe with the permission of the faculty, I'll call the session a close and apologize for all the troubles which you have been having today, sir. I will ensure this does not repeat and ensure things are sorted out in a better way, sir. So, Kanna sir and others, any comments, sir? Mayank sir, Rohit sir and others?
No, sir, we understand. I think sometimes these online classes, they may be difficult to conduct. So yeah,
Yes, sir.
we can, yeah. Go ahead.
So we'll call the session a close, sir. Apologies for the day's event issues, and let me rectify that in a better way, and we'll take your help for the subsequent classes, sir. So with the permission of the faculty, we call the session a close, sir.
Thank you. Thank you, sir.
Thank you.
Thank you,
Thank you,
sir.
sir.
Very sorry for the inconvenience caused to all of you, sir.
Thank you very much, sir.